So today we will be discussing about ENT instruments used in OPD. Thoricum nasal speculum. This is a nasal speculum commonly used in ENT outpatient clinic. It is held over the hooked index finger of the non-dominant hand. The blades are then closed by pressing between middle and ring finger. While inserting into nasal cavity, the blades are fully closed, whereas during removal, it's partially open so as to avoid hair trapping. Uses: diagnostic uses, anterior rhinoscopy to see the nasal septum, details area, lateral wall of the nose, and nasal cavity as a whole. Therapeutic uses: removal of foreign bodies, nasal packing, chemical cauterization, minor surgical procedures inside nose. St. Clair Thompson nasal speculum. This nasal speculum is similar to Thoricum nasal speculum, except that the blades are longer here. The longer blades permit deeper visualization of the nasal cavity and its structures. So it can be used for nasal surgeries like septoplasty, SMR, polypectomy, or removal of foreign bodies lodged deep inside the nose. But its handling would be ergonomically difficult for longer procedures. VIENNA nasal speculum. This is how you hold a VIENNA nasal speculum and use it. So the uses are diagnostic in cases of anterior rhinoscopy, therapeutic for removal of foreign bodies, nasal packing, surgical procedures. The other instrument is PILCHER nasal speculum. This is a non-self-retaining nasal speculum used for anterior rhinoscopy examination in children. St. Clair Thompson posterior rhinoscopy mirror. This instrument has a bayonet-shaped handle, hence differs from that of indirect laryngoscopy mirror, so the examiner's hand doesn't block his vision. The mirror is available in sizes of 0 to 5 and should be of an appropriate size so as to pass behind soft palate and reflect sufficient light for the image to be seen. This is a plain mirror and does not magnify the image. Steps of posterior rhinoscopy. First of all, explain the procedure to the patient. The mirror surface is then warmed over spirit lamp and checked over the dorsum of hand for tolerability, or it can also be dipped in Savlon in order to prevent fogging during the procedure. The tongue is depressed gently with a tongue depressor, and this mirror is introduced inside like a pen with the mirror facing upwards. The patient is asked to breathe through the nose. The mirror is now introduced behind the soft palate without touching the posterior pharyngeal wall to reflect the light towards the nasopharynx. Evaluation of structures done by rotating mirror all around. So these are the structures that you see in posterior rhinoscopy. TILLEY dressing forceps. This is an angled instrument with serrations only at the tip of the blades. It can also be used in ear and nose. Uses: for packing and unpacking the nose, for introduction of medicated places, for local anesthesia in the nasal cavity, removal of foreign body, crust, debris in the nose and ear, for packing or unpacking the ear canal or mustard cavity, for delivery of medicated dressings into the ear canal. MEROCEL nasal dressing. This is a safe, non-stick biocompatible material. It facilitates easy automatic removal after packing. It also clears clots and debris during removal, leaving a clean cavity. It is compressed for easy insertion and swells up subsequently after saline injection into it. It is used for packing nose following EPISTAXIS and septal surgeries. It can be placed in the nasal cavity for more than 48 hours. EPISTAXIS balloon catheter. This is a catheter made up of implant grade silicone that has an airway and can be used to control both anterior and posterior nasal bleeding. It has two separate bulbs that can be inflated with saline for anterior and posterior bleeding. It can be used as an alternative to nasal packing and has the advantage of allowing the patient to breathe through the nose. Types: single and double balloon catheter. In single balloon, only single inflatable balloon is present, which is used for anterior epistaxis. Double balloon catheter has two inflatable balloon present, used for posterior epistaxis. Posterior balloon is inflated and pulled up to choana, then anterior balloon is inflated. Flexible nasopharyngolaryngoscope. Nasopharyngolaryngoscope or NPL is used to view the nasal cavity, nasopharynx, laryngopharynx, and larynx. The tip is movable distally and hence can enter the crevices and spaces inside the nasal cavity. These scopes can also be used to visualize the laryngeal inlet and hypopharynx. The FIBEROPtics can be connected to a camera for magnification and better visualization, and also for recording of the images. Desmond-Rieux, 1853, is called the father of endoscopy. He redesigned Bosini's endoscope by attaching a gas light and condensers to project a beam of light down the tube. Otoendoscope. This is a short rigid telescope, usually of 10 cm length and varying diameter, like 1.9, 2.7, 3.4 mm. It is available in 0, 30, 45 and 70 degree angles. It has to be connected to a fiber optic light source for illumination. Used to examine the external auditory canal, tympanic membrane and middle ear, the findings can be recorded through a camera. Nasal endoscope, rigid. Rigid nasal endoscope are adult or pediatric ones. According to diameter, adult one is 4 mm in diameter, whereas pediatric, the outer diameter is 2.7 mm. A range is 0, 30, 45, 70, 90 and 120 degrees, which is 18 cm long. 0 degree scope is the most commonly used of all, as it has a direct forward-looking orientation. The 30 degree endoscope is the endoscope of choice for diagnostic nasal endoscopy. It allows better visualization of the structures in the lateral wall of nose. The 70 and 90 degree scopes are useful to visualize work in the frontal recesses and the maxillary antrum. They are also useful to visualize the laryngeal and hypopharyngeal inlet as an alternative to indirect laryngoscopy. The 120 degree scope is used to inspect the anterior wall of the maxilla through the antrostomy opening. Color code for endoscopes. 0 degree is green. It has a green marking. 30 degree has a red one. 45 degree has a black. And 70 degree has a yellow one. Fiber optic flexible light cable. This cable contains flexible optical fibers that transmit light by total internal reflection. This is used to transmit light from the light source to the endoscope or the light carrier. Halogen portable light source. This is a portable light source used for direct laryngoscopy, bronchoscopy, esophagoscopy, hypopharyngoscopy, nasal endoscopy, NPL. It has a special bulb of 150 watt that requires a fan to cool it regularly. Fiber optic headlight. This consists of a headband, a fiber optic light cable, and a concave mirror. The light cable is connected to a suitable light source of 150 to 250 watt. This light is transmitted through the light cable by total internal reflection to the headlight. Ohm atomizer. It has a rubber bulb, rubber tube, glass bottle containing liquid anesthetic, and spray shaft. Uses: to spray local anesthetic agent like 4% lignocaine on the posterior pharyngeal wall before examination, to spray local anesthetic in the nose before diagnostic nasal endoscopy, before biopsy of ulcers or swelling in oral cavity or oropharynx, tongue depressor, lax tongue depressor. It has a flat end and a slightly curved end. The flat end is placed over the anterior 2/3 of the tongue to depress it. The posterior 1/3 should not be touched in order to prevent gag reflex. Uses of this instrument is in examination of oral cavity and oropharynx, to retract lips and cheek, to express pus out of tonsil, to test gag reflex, for cold spatula test to check patency of nasal passages, for posterior rhinoscopy, for oral cavity procedures like injection of steroids, biopsy, excision of cysts, etc. St. Clair Thompson QUINSY FORCEP. It is a bayonet-shaped instrument with a sharp trocar tip. It has a guard at some distance from tip to prevent deep entry. For draining quinsy, sharp tip is pierced with the forceps closed. The instrument is then opened like a sinus forceps to drain the abscess. This is the site of drainage of peritonsillar abscess. So if the QUINSY forceps is not available, a stab knife can also be used. Indirect laryngoscopy mirror. This mirror was originally invented by Manuel Garcia of Spain in 1855. It has a handle, shaft and a plane mirror at an angle. The focal length of this mirror is at infinity. The mirror is available in various sizes ranging from 8 mm to 30 mm. Steps. So before starting the procedure, you have to explain the procedure to the patient. The mirror surface is warmed over spirit lamp and checked over dorsum of hand for tolerability, or dipped in savolon in order to prevent fogging during the procedure. The patient is asked to open the mouth and protrude the tongue. The tongue is held with a dry gauze piece with the left hand. The handle of the mirror is held like a pen and gently introduced into the oral cavity and finally placed against the soft palate and uvula without touching the postopharyngeal wall. The patient is asked to breathe through the mouth. The patient is asked to phonate E for observing vocal cord adduction and is asked to breathe gently for observing vocal cord abduction. So these are the structures which are seen in indirect laryngoscopy. Here is the picture of indirect laryngoscopy. You can see the epiglottis, false vocal cord, true cord, arytenoid, interarytenoid joint, pyriform fossa, vallecula, base of tongue, aryepiglottic fold and subglottis. Uses. For examination of tongue base, vallecula, glossoepiglottic fold, pharyngoepiglottic fold, arytenoids, aryepiglottic fold, ventricular bands, vocal cord, interarytenoid region, pyriform fossa and posterior pharyngeal wall. These regions can be examined for any foreign body, inflammatory, non-inflammatory, traumatic or neoplastic lesions. To remove small foreign body like fish bone from these areas, to remove tissues for histopathological examination. Structures which are not seen in indirect laryngoscopy. Postcricoid region, apex of pyriform fossa, anterior commissure, ventricles, undersurface of vocal cord and adjoining subglottic region, laryngeal surface of epiglottis. Pitfalls of indirect laryngoscopy. There is anterior and posterior reversal of structures in the mirror image. Overhanging of epiglottis may obscure vision. The anterior commissure is poorly visualized. Depth perception is poor. The procedure is difficult in children. The tongue may rise in phonation and may obscure the view of larynx. The procedure is difficult in a person with short neck. The vocal cords appear short and flat in the mirror. The vocal cords appear white due to reflection of a greater amount of light to the mirror. Manuel Garcia was a singing teacher who was interested in the physiology of human voice. He made a long-handled mirror to observe the interior of the larynx during singing. He described the action of the vocal cords during inspiration, expiration, and vocalization. He recorded his observations of the production of sound in the larynx. Garcia is recognized as the first successful laryngoscopist because of his accurate, detailed recording of these observations. He is considered to be the father of laryngology. Guiding probe. This instrument is placed under the tongue to engage the frenulum before cutting it. Young-Cure nasopharyngoscope. This is an instrument used to examine the nasopharynx. The patient is kept in supine position and the head extended. The instrument is inserted under the soft palate and can be used to examine the nasopharynx as well as to take biopsies from the region. Thank you for listening.